Дорогі друзі,
Dear friends, good afternoon. We continue our work. I'm Andrei Yelinsky. I'm the medical director of the Shupyk Center and the advisor to the Minister of Health. I will moderate this session. It's dedicated to the medical care, primary medical care. In this year, 2025, we had 7 years from the moment of the start of the reform of the financing of the healthcare of Ukraine. This time, flight passed. The reform began from the reforming of the primary medical care. It seemed to us to be easier to do. But also, we all understood that the primary care is the foundation of our medical care in our future. In 2019, we launched the program of the reimbursement of the medications, which is successfully being developed today. And in 2022, various institutions of specialized medical institutions joined the reform. And you all remember the pandemic of COVID. There were challenges also during the invasion. And this year, to the new mechanism of financing new facilities joined the Academy of Medical Sciences, so we are moving forward. But we have a question now. These reforms that we began 7 years ago, how successful are they? How are they showing, how are they reflected in the health of our population, taking into consideration our challenges, where we succeeded, where we made mistakes, what we need to correct? So today, we dedicate the session to these issues, these questions. But first, I would like to hold a poll. And on our agenda, we have 3 questions to you. So please take your remote controls and please answer these questions. These are very simple questions. The first one, do you have a declaration with your family doctor? Please vote. It was so we are accumulating the votes. Okay, we can announce the results. You can see them on the screen. 64.71% do have a declaration with the family doctor, and 35% don't have. They differ, these numbers, from the overall numbers in Ukraine. You know, the coverage with declaration in various regions is about 90%, up to 90. So the medical doctor community, unfortunately, they don't usually come for help to the family doctors. Maybe they don't believe this kind of help will be effective. Second question, have you visited your family doctor this year? So obviously it's a question to those who have the declaration. As I see, there is people who don't have the declaration probably didn't vote. Some of them maybe did, but so we have 70% of people who actively use this service of family doctor. And the last question, are you happy with the quality of the service provided to you by the family doctor? It's a yes or no. Thank you. So 94% of us used the services of the family doctor in the last year are satisfied with the service. Let's keep it for as our memory's sake, and I would like to give this word to Alexander Tolstanov, the professor, vice rector of the Shupyk University of Ukraine and the president of Association of Family Doctors of Ukraine. Thank you, Andrei Borisovich. Thank you, the members of the Presidium. Thank you for my colleagues for um, staying here for this panel, because in the morning there were more people, but you know our mentality, right? First you come here to check in and then you get down to work. So if you allow me, please, my presentation, if possible. So the Ukrainian Federation of Professional Medical Associations delegated me to at the order of the Minister of the Viktor Lyashko, the Minister of Health of Ukraine. And this order was voiced at the previous summit that we need to hold a separate panel about family medicine, the development, the visions, the problems. So this order is being implemented. We created this panel, and moreover, today there was a decision of the Ukrainian Association, which has a legal status, 14 divisions, separate divisions. Today we decided to tell you about our vision of how to provide primary medical care in the conditions that unfortunately are continuing today in relation to the invasion, aggression of Russia against us. We also will tell you a little bit about how, in what way we visited, because we just got back from the Worldwide Congress of the Worldwide Federation of the Family Doctors in Lisbon, and we had an opportunity to give a speech there. And this speech was taken into account in the resolution, so we will mention that. And at the end, certain considerations and thoughts that we need to take into account so that we don't stop what we have started in this reform of primary care. So my colleague the member of the board, will take the floor to speak. He's here in the presidium. He will tell you. So let's start. How do we see our primary health care? The family medicine, it's not a tool of effective management in medicine and effective usage of resources and communities, but also our personal funds. It's the most tried and evidence-based, tested, the most evidence-based union of patients and doctors, and it helps to meet the requirements of the healthcare. So it's like a bridge between a doctor and the patient, and it helps us do something we are aiming at, not just in our country, but everywhere. We are talking about a person when they have a need, and even before they have a need, they should talk and use this opportunity to meet the professional, not the Facebook messages or ads. Because a person who has a medical education and understands the needs of the patients, they should be the first on the front line. So the war, which has been lasting for more than 3.5 years, there are unprecedented challenges because of the war in our system, but all the messages that we could deliver to the worldwide European Congress, they surprised our counterparts in the entire world. How, in these conditions, Ukraine and our healthcare system still is still providing primary medical care. You know how many medical facilities have been damaged and destroyed, and we can't really rebuild them in the in wartime, and it's continuing to happen, unfortunately. And of course, the resources are being depleted, and the resilience of the system is going down. But also there is psychiatric health, mental health is a problem, and the WHO says that more than 9 million Ukrainians have some psychological disorders. In any country of the world, I would like to tell you from this stage that today the general practitioner or family doctor is the first medical worker who is there at the site of the event, in the very center of the battlefield and its aftermath and pandemics and all other crisis situations. So together with you, I would like to analyze the data that were the project of HEMS Ukraine of WHO in February 2025. It's the data. You can see how many facilities, healthcare facilities, in 10 the most affected regions affected by war. So the next table is about the regions that are not so much affected. So what do you see in this table? Why am I showing you this? I would like for you to see that the accessibility of services. You see general services, health of children, sexually transmitted infections, help to mothers and newborn. You see the accessibility of services, general, children's health, infections, and you see the color, the blue, it's accessible. The yellow is not accessible, and pink is partially accessible. But the most interesting are the ones on to the right, the main challenges that that hinder the realization of services. And you see on the left the things that I mentioned before. Uh, ch- Children's health, help to mothers, sexually transmitted disease, and in the colors and percentage you see the lack of personnel. It's light pink. Lack of training, a more intense purple color, you see. You see, as university people, we are very interested in this part, the lack of professional training. So together with lack of equipment, these are the dominant obstacles that in the wartime hinder our process and our compliance with the necessary standards. Now you see the other 13 regions of our country, apart from the other 10 that took part in the experiment in February 2025 by WHO. Here we are analyzing more regarding the delivered services, the emergency medical care, the sorting, basic emergency care, extended care, syndrome care, also referrals, transportation, acceptance of referrals. So the middle column you see this is what is related to the accessibility in percentage. It differs a lot, as you see. The medical sorting is accessible, basic emergency is accessible, but only 21% the emergency care at the request of the patient. So if you look to the right, you can see these pictures. You see the medical care, you see training and education, you see medication supply and financing. So what we are interested in this experience, it's about education and training. You see that of today, this is a very acute issue. And not only our university should respond to, but only also the others. In 2019, the WHO, uh, the Worldwide Organization of Family Medicine, adopted a concept. As you see in this concept, you can see the circle which is supposed to be complied with no matter what, no matter which country this is and in what way, how it happens. The goal of this circle is to it's to minimize the negative impact in the conditions of catastrophes, risks for women, children, people with disabilities, and other vulnerable categories of people. What is needed is the implementation of this approach. First, it's prevention. If you go clockwise, second is readiness, then event, then response, then recovery. So, if you stick to the circle, if you listen to Donald Lee, the former president of Wonka, the role of the family doctor in problems, emergency problems, is key. It's not just our mottos. It's not our bragging. It's evidence based that the family doctor's role is the key in this. The competences in most countries of the world are not enough, and in some countries they are absent at all. So this is the conclusion I mentioned on my previous slides. So how can we become better in the circumstances of wartime, the family medicine? How can we keep the successes we already achieved and not lose our positions? First, it's the management of the primary medical care. We, we also, so the continuity of care is important and the maximum protection of the public. What is main is the patient-oriented care, to be first at the site of the event, the family doctor. Say mental health, communication of the risks, comprehensive approach is a must. Also working with vulnerable groups of people and community orientation. Without the community, family doctors' work is impossible. Also deficit of materials, supplies, and medications. Also the ethical issues during catastrophes and war. Dear colleagues, I promised you and I inform you that the first the speech we had at the resolution at WONCA 2025, it was called the strengthening of the capacities and the role of the family medicine in issues of emergencies and catastrophes. So our four positions, the positions of Ukrainian family doctors were taken into account, and it was taken into account in the worldwide resolution. So to foster the creation of the working group WONCA with representatives of stakeholders, then to develop the declaration and to publish it regarding the role of family medicine in issues of catastrophes and emergencies. The third proposition is very important. It was to create module training program to strengthen the competencies of doctors. Also the protocols of actions in emergencies and interactions with the international response system. Also to foster the creation of joint projects, OneCow, WHO, and other national professional associations. So we are ready to take active part in this, and we have something what to show you. You know that UFPMO, which we are a member of as an association, was proposed to create a working group to develop the professional standard of the general practitioner. The prototype we used, we took the best international practice, the competences of the specialty of the family medicine, the structure of the competence of the family doctors of Canada. We also took it as a structure. Also, the Royal College structure of competences and Australian structure of competences. So this is how we are developing the standards that will later be adopted. So the framework, as you understand, we created the framework for competencies of the family doctors. There are 6 units. I will not go into detail, and more than 40 basic competencies. I will just name you the units, and I ask you to be actively involved. We are collecting proposals regarding the 6 units, because when writing the standard, we write it ourselves. We need to take all of that into account. It should be put to work. So organization of professional activities, consultations, work with patients, preventative care, professional development. So the role of professional association and unions. First is educational function, development of standard module programs for integration to the existing system of education of doctors, and creating textbooks, algorithms, scenarios, and simulation centers and trainings, not just because we wanted, but because you saw the previous research study of the WHO. So it says more than 5,000 respondents said that doctors need additional knowledge. So creating international work groups for development of recommendations and guidelines. So together with OneCo, we'll work on it. Advocation and promoting integration ideas. So in this third part of my speech, the association decided to share with you what we consider as 3 components of the successful actions of the family doctors. So the 3 areas, main areas: management, financing, and delivery of services. Nothing new, it's rather classic, but let's try to go into detail and see what we have for now and what needs to be done. So in management, we suggest leadership and partnership in forming the policies instead of reflections on our problems. So the Ministry of Health of Ukraine forms the policy in this sphere, and they control the compliance with the legislation. Nothing else to make up. This is how it is. This is how it will be. Medical
Medical community is a source of idea. It creates professional and expert vision. It regulates aspects of professional activity that can be regulated only by professional community. It determines the foundation of profession, best practice requirements. It conducts clinical audit, ensures continuous professional development, conflict mediation, and quality arbitration. These functions are inherent for medical community and medical self-governance body rather than central executive authority which formulates a policy and controls its enforcement. Local self-government is an essential component. General practice doctors cannot go without it, so local self-government must ensure conditions for implementations of state governments, so physical accessibility of primary health care. Local self-government must always have information about health of community population and factors of impact, because otherwise it won't be able to form its policy. Luckily, we have public health centers, and it's already implemented in Ukraine. It also develops the information system to collect data about medical needs of healthcare providers, citizens, and essential and medical statistics essential for planning. Managerial decisions are to be made based on data collected. Secondly, it's a very complicated area, but obviously we cannot go without it. Funding. We would like family medicine to further develop. We want the economy of development and efficiency rather than economy of survival, fines and penalties. Tariffs must always take into account targeted prevention plus incentives, so it equals to efficiency and quality of primary health care. Yes, this rate covers the operational costs, but we need to add coefficients for special conditions, frontline areas, rural areas, regions with austere conditions. We also require target fundings to boost outreach, so programmatic targeted method, because prevention results actually manifest only after a few years after taking measures, and according to many national and global experts, the 5 years is a relevant horizon for assessment. So positive economic incentives, it require quality indicators. It's always a very complicated issue, and the whole evaluation is a difficult process, but we can't go without it. Efficient operation of primary health care inevitably results in reduced need in specialized emergency services and therefore reduces the expenditures of the entire healthcare system about free distribution of patients. And here, I definitely have to share with you this passage because this is the data we have collected from multiple organizations. So, selection of a healthcare provider, it's my personal opinion. A citizen has a right to select a healthcare provider, but every idea has some factors to be which should be given due regard to. Selection of healthcare provider which practices far away from the place of residence is costly. So potentially we may provide for franchise to the tariff guaranteed by the government. Free, unlimited distribution creates certain issues. For example, organization of emergency care, identification of socially hazardous disease outbreak, patronage over patients with special needs. For example, in United Kingdom, it's governed by customary law. They have a custom where doctors will never accept a patient into practice if there are practitioners located at a closer distance. Of course, people have to select a doctor, but we need more differentiated approach. Therefore, accessibility standards for doctors and nurses, availability standards for workload standards for doctors and nurses must be guideline for community. Second is a regulated market rather than improvised market. Here we need to talk about incentives for communities to develop networks. Communities need to have enough resources and incentives to create practice rather than waiting for someone to come in. So, if you want to have a medical practice, create conditions. Make sure that doctors wish to work in your community. Right now, the law is under development regarding development of competencies between public governance and initiatives. According to initiative of the Ukrainian Association of United Amalgamated Territorial Communities, we have signed memorandum with, and our experts are engaged in the process. We hope that this draft law will further strengthen the role of community in supporting general practitioners. We always need to remember about public-private partnerships. No, it won't go anywhere So it's essential to encourage communities to ensure equal conditions for primary healthcare providers regardless of the legal form of ownership. I mean ensuring access to primary healthcare, and I know that today we're about to discuss it. So expected outcomes. Any opinion of can't go without expected outcomes. So what do we expect? For government and political leadership, it's a reputational achievement, creation of positive expectations, and consistent implementation, which will impact the most important asset of our country, our human capital. For medical businesses, it's about equal and mutually beneficial cooperation in provision of primary health care. For healthcare provider, it's a satisfaction and the process of implementation of state guarantees you've just heard. So for benefits for communities, understandable rules for local healthcare policies and for patients who are interested in their own health. Well, healthcare providers might be interested in the health of their patients, regardless of the form of ownership, and growing satisfaction rate with a healthcare policy in a society. And here, primary healthcare is of utmost importance. We believe that our main duty is to reduce negative impact of disasters on public health, especially in vulnerable group. Family doctors is not just a foundation of the healthcare system. During peacetime, it's also support for social resilience during war, outbreaks and disasters. Actually, that's what we observe right now. Thank you so much for your attention. And sorry for being a little bit late. Just I had to let this the gathering, inform this online gathering, ongoing events. Thank you. So I'm ready to answer any questions, or we will keep discussion for later. Thank you for this substantial report. As experienced and talented speaker, you already preempted questions to be asked by a moderator, and you have already responded them in your presentation. So we had the following questions. What are the current challenges, what the current concerns for family doctors community? Because here we represent professional associations. This is a tariff rate. This is the scope of primary medical care services, whether to expand it or not, and its strengthening monitoring by the National Health Service. So these are the issues which are the most concerns for professional community, and you have already partially or fully answered them. But I'm a person who, for a while, has been involved in implementation of this reform. I mean healthcare system funding reform. Here I want to discuss with you the free choice of healthcare provider, because here we may have some conflicts with the legislator, and I want to learn more about your vision, how to resolve this conflict from a point of view of law. From the point of view of regulatory framework, I don't see any solutions in the regulatory framework. This is the reason why during my presentation I say that Alexander Tolstanov personally believes that free choice of healthcare provider is great and it's inherent right, civil right. But honestly, Andrei Borisovich, many of our colleagues asked me to voice this concern. I do voice this concern with the only purpose in mind. There are some cases in the world where the countries independently developed a mechanism where doctors do not accept patients from afar. This is the reason why we may apply it to emergency care, for example. Like imagine a large city, like a Kiev, city of Kiev. A person won't go to the ambulance won't go to a different part of Kiev to provide emergency care. So here we talk primarily about emergencies. So knowing that the Ministry of Health initiated this gathering, we just wanted to start this discussion, maybe to pilot this model somewhere in a small community and then make a conclusion. But I shared with you my personal opinion as well. Thank you so much, dear colleagues. Do we have any questions to Mr. Konstantin from our audience? We need a microphone. Olga Parahomenko, Medical Director of University Clinic, Odessa National Medical University. I have a question for you. Don't you think that the workload of family doctors and both adult and pediatricians is extremely high? You mean the number of serviced population? Yes, number of declarations. Why am I saying it? I started to work in the city of Kherson as a family doctor, so primary health care. And yes, tariffs, money, clinics want to get more revenues. So they wanted us to make 1,800 declarations, but it's extreme workload, and therefore the quality of medical care becomes really low. You simply don't have time to offer prevention, treatment, and really dive deep into a case. And when the COVID started, it was a pure nightmare. It was a real nightmare. Please continue. So, I know that in some countries there is a practice where number of declared population is at least somewhat limited. And even young doctors, young professionals sometimes get scared. They don't want to go to become family doctors. They don't want to join primary health care system because they observe it and they are terrified by it. If you don't mind, I'll respond to your speech. Finally, if we have a situation in our country, please don't stand up because otherwise I will have to stand up as well. Please sit down. So in our country, we're slowly building a different paradigm of a family medicine. Yes, we still have some legacy, but it's very different from how we started. If you get poor grades at the university, you will become a family doctor. It's very difficult to destroy this bias, but we're slowly doing it. Why are we doing it? This is the reason why I bring attention to local communities, so people don't think that it's up for capital cities only. It's about monetary incentives. It's about housing loans. It's about vehicle loans. I mean, not to gift, but to give them, just to make sure a person is grounded and rooted in the area. Then, it has been discussed since 2008, and in some regions it's still not addressed. I am also lucky, as Andrei Borisovich says. I had the chance to participate in the experiment in 4 regions with primary health care, and I not just participated, but I actually managed this direction. So I really saw what you were talking about. This is not just a random number. It's just average. It's average for many countries. I mean, number of outreach population. We needed a kind of baseline. So if you just ask me, and maybe my colleagues won't agree with me, but I would say that this is a normal figure. Maybe Alexander Borisovich can comment on this figure, because he directly works in field in Kramatorsk. Actually, we need to learn how to properly plan our workload and how to differentiate care we can provide and care we can just outsource and control. So the main idea here is a team play, not just outpatient, but also at primary health care centers. That's how we will be able to engage consultants and thus reduce the workload. But 1,000, well, I don't think it will be a right option for Ukraine. I mean 1,000 declarations. And another thing. Yes, indeed, you're absolutely correct about pandemics. But we have 5 years. But it was very difficult to practice some standard in 5 years. So this is the reason why part of my report is focused on this disaster management risks. Actually, people in other countries are simply fascinated by the data we provide. So you mentioned teamwork. Okay, great. But family doctor must to give a referral. It means an appointment. Do you want to remove referrals or what do you want? I want to optimize it. Just think. People do not understand. Person says and says, I need a cardiologist. And you will never convince them that they don't. We have this experience of 10 years. It's not yet enough to change the mindset of our population. So the time is not enough. But I personally believe that general practitioners must be the first. It's not just you just call a phone number and try to make an appointment. I'm sorry. It's not like I'm triggered by it, but I love your approach. This is the reason why, well, sometimes when you work with it, family doctors are sometimes affected by it. People often perceive you just as a gateway to appointment with cardiologist, neurologist, etc. People don't care what do I think. So we had a 4 years experience, 3 years of experience. Went to Vinnytsia. There's an old downtown and a downtown. And in old town they had the general practitioners and they made a decision without Ministry of Healthcare that children below the age of 5 are not referred. I remember a person with 15 years of experience. This is a process. This is a huge process, but it's supposed to be exactly like this and nothing else. Thank you, dear colleagues. Please be brief with your questions, because we have to stick to our agenda, to our schedule. But I want to briefly comment on the discussion I've just heard. I think we need to understand why are we doing this reform and who's the most important link in our healthcare system. Of course, we're doing it for patient. So the main question we have to answer is that there is primary health care service accessible for patients, and second is the quality of the service. There will be always a discussion. The resources will be always limited. The workloads will be always high. So we need to increase the rate. We understand it. But colleagues, here I actually agree with Alexander Konstantinovich. Many things depend on you and me. How do we work with population? Do we convince? Do we prevent health conditions at our level? Do we have trust of our patient? Why do they come to us? Do they come to receive a medical service or simply receive a referral? These are the questions community must ask to itself. So thank you so much for the first part of this discussion. Thank you for your brilliant report. And now I kindly invite Alexandra Kozlovska, Vice President of Ukrainian Federation of Professional Medical Associations. Hello, colleagues. Could you please share my slides on the screen? So today, I will tell you a little bit about our project. In addition to being elected as Vice President today, for several years I have led Med Global Ukraine NGO, and we have decided to implement a project. And today I want to introduce this project to you. The name of this project is Strengthening Primary Health Care and Real Identification of Non-Contagious Diseases in Communities, non-communicable diseases. Why do we want to share it with you? Because we believe that this project is very important. We have already received some positive feedback, and today I really want to present it to the medical community. First of all, primary health care providers, family doctors, I want to collect your feedback. Are projects like this needed? And is there a sense in spending money on it? So why have we picked this particular project? Actually, we have a large project portfolio we're implementing. Our main our main activity is training for doctors, conducted by our American colleagues who are present in this hall today. Next week we will travel to Vinnytsia to do trainings. Maybe some of you have already visited some of them. But we picked this project for a reason. It was driven by evidence, by statistical data. So according to WHO, according to our state statistical service, what is the main reason of mortality? These are cardiovascular conditions and diabetes, so non-communicable diseases. So our organization pursues a mission of early diagnostics, prevention, and because we want to contribute to decrease these figures you see on the screen right now. So we have decided to do this project, strengthening primary healthcare and early identification of incommunicable diseases in Ukraine. We have picked Kiev region because Kiev region was occupied in 2022. A part of Kiev region, we mostly work in liberated communities, and there is also a number of reasons I will explain to you a bit later. So we implement this project as a partnership. We don't have a license. Our organization doesn't have a medical practice license. We don't have medical professionals. This is the reason why we cooperate with Yavashikya Medical Service, who provides services to center communities, where we implement our project. Of course, this project is very expensive, so to say, and this is the reason why I really need your opinion. Do we even need a project like this? We receive funding from Latter-day Saint Christ Foundation and from our American partners. That's how we implement it. So why Kiev region? Why have we picked Kiev region? Because it's one of the most affected by conflict. Of course, we cannot compare it with the eastern part of Ukraine, but we wanted a relatively safe area. In the region, there are partially destroyed healthcare facilities which provided primary healthcare services, and Kiev region is also overpopulated with a few hundred, so 320,000 IDPs. So we try to cover residents of remote settlements in communities of Kiev region who don't have full access to free of charge medical care. Here we talk not just about primary health care, we also talk about lab tests, about certain diagnostic tests for early detection, prevention, and interventions for non-communicable diseases. So what this project is about? We purchased modern portative diagnostic equipment, portable complex, which includes special devices for lab tests and device-assisted tests. This equipment will enable healthcare providers to timely and efficiently diagnose non-communicable diseases, cardiovascular, diabetes, and other chronic conditions. So, along with our partners, we have created 6 mobile crews, which operate as part of this project. Of course, we started with trainings. We have 33 doctors, we have nurses who do these tests. Here we have some pictures of how it happens, how it usually works in practice. So diagnostics is done, diagnostic tests are done by nurses. Here you see, one appointment, one click consultation. It's a kind of slogan of our project. On the picture you see a nurse who's doing all these tests, and all these tests are automatically test results are automatically uploaded to the software. So this small device you see on the screen. We also have a quick access to study results. Why it's so important? There is, today we deal with a high mobility population. Some people are staying abroad, return to Ukraine, once again travel abroad, and after this diagnostics, they receive test. So a person may provide to any doctor this QR code to access websites. And so the entire info, lab tests, primary test results will be available. So a person has a code and don't need to to keep a pile of paper which can be destroyed in a healthcare fire, in a shop fire, or for displacement. Basically, a person has just a code and can see the history of diagnostic interventions. Another important thing, we have focused on people who have limited access to primary healthcare. Why limited? Either they live in remote territorial communities or they have limited mobility as these people, mobility, or they are from low-income background, because as part of this program we provide not just free of charge primary healthcare packages, but we also provide some additional laboratory tests. So, as my colleague Alexandra Konstantinovich previously mentioned, they discussed referrals, whether we do it or not. We just so we offer extra studies which require referrals. Endocrinology, lab tests, they are now available free of charge, while most of our patients, they are from low-income background and they cannot afford paying for these services.
Laboratory tests or diagnostic services. We also focused on the medical team. They go to the centers of social care, of long-term care, neurological and psychiatrists in nursery homes to do the comprehensive tests, health checks, because they don't have their own labs. And we have the mobile complex, like mobile lab equipment. So comprehensively, you can do this. You can perform these tests when you go on site. You can see these pictures to understand how it happens. It's all very mobile. It's unequipped site. All you need is just a table and a bed in order to perform these tests. So what is important? Important conclusions, intermediary results of the project is mass tests, which helps us do the screening in any types of circumstances, even in rural areas when the doctor is not there. So the various medical personnel can do certain types of tests. Speaking about the lab test, of course, you need the capillary blood and automated analyzers. We started the project on the 1st of August. You can see it on the slide. Uh, 1,200 persons were tested, so 5,000 tests performed. You can see, and what we do and our partners do, the blood pressure, heart rate, non-invasive measurement of pulse, electrocardiogram, lung tests, biochemical tests of the blood and urine tests, 11 names, various markers, lipids, biochemistry, and then we check whether additional tests are necessary. So this is the most important slide. I really like it. It's about the fact that we do it not free. We don't do it just for the sake of it. 280 tests is 22% of the overall number of tests. Uh, so, um, so here we found the cardiovascular disease markers, and we found the very high risk of cardiovascular disease. 10 people is not much, but every life is valuable. So for us, it's a valuable number. What also HbA1c, glycated hemoglobin. When we tested glucose, it was fine, but the glycated hemoglobin is to give a free test. It's performed by the referral of endocrinologist. So 20%, around 20%, we detected the diabetes. You can see the screen, how the screen looks. It's a digital interface, automated data export. It's a cloud protected service of analysis and storage. So the risk factor, human risk factor is minimized. So I can hear in the patient community and NGOs community, in healthy, they have messages that you visited a family doctor, but you have never been, you haven't seen your family doctor for 2 years. So it's manipulation, actually. It's abuse in order to make more money from the unfaithful representatives of medical communities. This project, it makes this impossible because each patient, each automated measurement, it's all automated, and you can't do anything manually here. Why we do it? One more time to stress, it's a prevention and early detection of cardiovascular disease, diabetes, oncological diseases. It's very important, especially among the IDPs, because from 2022, the prevention, unfortunately, people stopped paying attention to this because the main goal is to just survive, but the quality of life for us is also important, to have a certain level of quality of life and to detect this non-infectious disease at an early stage. So the better we do it, the prevention and the diagnostics in time, the more stable the population will be and economical condition of our communities also. So to finish my presentation, why I decided to show you this. It's not a forum format, it's a more professional discussion, but I'm talking like a donor mainly. It's because we want for these projects to be done not only at the expense of the donors. We really value and we really welcome that in 2026 in the state budget they allocated certain funds for checkups um, for people over 40 years old. So we communicate this all the time to the representatives of the government that there should be a certain level of attention to prevention, to early detection, because it's not only about the quality of life, it's only about the lifespan, it's also about the money. The earlier we detect the disease, the fewer funds need to be spent to treat this person for a disease. So I thank you very much, and I am ready to take your questions if you have any, and if you have any feedback, I would love to hear it. Thank you. Thank you, Mr. Alexandra. It's a panel discussion, so I would like to give the floor to the members of this panel. Alexander Konstantinovich, we will remember that there is a question and dear colleagues, dear Alexandra, I would like first of all to thank you for your understanding and for voicing this necessity for the Ukrainian Association of Family Medicine would give its preliminary feedback about this. I know about your plans. I have got acquainted with them. You plan you plan to expand. So in short, definitely you have to do it. And to this is how you finished your speech. The more we invest into prevention, the earlier we detect the disease, the less we use the secondary care. It's an axiom. Dear colleagues, really, the Ukrainian Association of Family Medicine, we support this initiative about 45 plus years of age, with certain checkups. This initiative is in the essence of the family medicine, the essence of the family doctor, the preventative component. It's one of the priorities of the activities of any general practitioner doctor and the team of primary medical care in the entire world, not only in Ukraine. So, and these are risk factors of cardiovascular, diabetes, right on spot. Right on spot, you started doing these checkups. More than that, the numbers you showed us, they really impress me. They impress me with what else you can do further. And you don't have to really talk the patient into it. You don't have to waste your time on the family doctor. Because for the patient, it's not just a checkup. It's a it's a proof of something that they must do, and it doesn't really go against the order of the delivery of primary care services. Um, it's order 504. So whatever you're going to do, I support it. But there is one more positive but. You are not only defined that you will take part of this order and you will act on it. You went further than that. You went to the places where not all every doctor will go. You approach the categories of population that don't often go to see the doctor. So you're improving and you proved that covering this preventative so the preventative component will give positive outcomes. So we fully support you. If you allow me, I would also like to add that we are not just ready. We can give you a detailed feedback. Just give us a little bit of time. We will take your numbers. We will take our focus groups and other groups, and we will give it to the local government in every region that please let's learn how to spend the funds, and then you will receive the certain conclusion. This is how I would do it. So about your expansion, I got acquainted with it briefly. We are ready to give you the feedback in detail. What you should do with the screening, what standards are there in the world, because there are different local administrations and local communities, and they will tell you, some people in some countries use this, but we will prove this to you. We will show you the 100% evidence-based. Thanks. Thank you, colleagues. Any questions from the members of the panels? Question from the from the audience? Hi, Denis Dudko. I'm so pleased to see the goods of the Ukrainian manufacturer. It's a UTAS company. It's a very good equipment. It's not an advertisement, but it's very good equipment. I already wrote to family doctors about this opportunity. So approximately, comparing to other complexes in our kit, this is really about quality. It's like a local Lada and Mercedes car. So I'm asking as a practitioner. Yes, I can tell you the average cost of project, not the equipment. I don't know about the equipment. You need to talk about the with the manufacturer. Maybe it's commercial secret. I don't know. But the general cost of the project, data collection analytics, we plan to do 23,000 checkups, and it's about 300,000 USD. So it's all together, not just the equipment, what we are financing as part of this project. Any more questions, please? Hi, Marina Pavlovska, Director of the Primary Health Center, Kiev. Ms. Alexander, your vision of the mechanism of implementation of this project in our today's system of the payment for primary care delivery, because we work at the capitation rate, so it's cholesterol measurement, glucose, other screening things, and consultation of the doctor is included. So the medical guarantee program uh, presupposes premiums to the facilities that do the checkups uh, aged for patients aged 44 to 65. So will this be additional financing from the state, or will you make the facilities to buy this equipment, or this equipment will be for the facilities that support patients in remote regions of Ukraine? Second, how will you connect this data with the medical informational system, because we have a lot of them functioning now. We are now working in this with Healthy Health 24. So how this data you received from this apparatus, how will they combine with this data that how is it going to be somehow synchronized? Or it's important for us as practitioners. So first, our vision about the financing. Why is it important? As I mentioned in my speech, unfortunately, there is not some some manual some cases of putting it into the system, the fake visits, which they get paid for. So this is why we made this pilot, because there is no human factor here. There can be expansion, like glycated hemoglobin, for example. It's not within the primary care. The same financing could be for this, but these measurements, these diagnostics should be done with automated sets, and it would be put into the system. So how are we working now? Since we are working with a private center, all this information, it's coded, it's ciphered, and with certain codes, it's provided to family doctors. So if this person has a declaration with a family doctor, it's put into the MIS system. It's full synchronization with any kind of information system. Now it's a private project, but if we expand it, as far as I know, in some centers of primary medical care, there is also such type of equipment, and they just take this information and it's automated from this equipment. It's transferred to MIS system. So we are sharing the data now with the agreement of the patient and the family doctors, and then it's all synchronized with the MIS system. Not as part of our project, but they have to sign this certain agreement if they like to sign it. So why is it important? It's because it's not that we are talking about making it more expensive or less expensive. It's about how to have the real picture, not just something on paper. You can write whatever on paper, but why is there is digitalization everywhere now? In the tests, to remove the human factor, for the family doctor not to write, I had 10 visits of the patients, when in reality there was one. I don't want to discredit them, the family doctors, but unfortunately, we come across this. We see this as a good mechanism to avoid such cases and also to lower the load of the National Health Service of Ukraine. So if everything is automated, there will be no chance of such cases when you put fake data into the system when there was no actual patient visit. Thank you. One more question. Alexander Polishuk, Kyiv Community Director of Kyiv Center of Perinatal Care, Primary Care. I see that on our territory you did your studies, and I have a question. Was it a requirement of the donors about the selection just private medicine, or is it just a coincidence? So, and also on the premises of our enterprise, there was a project we worked on through USAID. Medical teams did similar things to provide services to patients with limited mobility. So if you want to expand, do you see the combination of our project and your project? Because we have specialists that are already trained, and to lower the costs of training for your staff, for example. First, why private center? It's not a requirement. Uh, it wasn't a requirement of the donor, but the private center in this project, it was in some parts co-financed. So we went private because it was difficult to co-finance it with municipal center. It will take too much time, it will not be effective. But with the private, they were ready and they wanted to do it, they wanted to help people. So we finance all the materials and all the equipment, but they finance visits on sites and salaries, etc. As to combine the projects, we are open to any kind of cooperation. After this panel, I will leave my contact information with you and we can have a discussion, and we are ready to any kind of cooperation and expansion, of course, yes. Thank you, colleagues. Okay, let's answer one more question. Charitable Fund Health, a medical expert. I have a question about the project. What was the outcome for the beneficiaries, except for the tests? Uh, Part of this project, I think as a project manager, though I'm a doctor, they received the test results. Okay, cool. But then what? Since they didn't communicate with family doctors, they just had other doctors visited. So these results, where did they go? And what percent of these patients received not just diagnostics, but also medical care? And the next one, if you work with mobile groups, as I see in funds, in remote areas, people, they get hooked up to these addicted to these mobile brigades, mobile groups, and then they don't want to go to primary medical care facilities. They all they do is they just wait for this mobile team to come and give them the meds. So it's not so good because the medicines run out, but the people still don't go and look for help anywhere. So how do you deal with this? I know you fund very well. Thank you for the question. We cooperated with humanitarian aid with you, medications distribution. So this project is not about mobile teams. We have a mobile team, a classical one, in the Kharkiv region. It's very close to the front line. So there is a primary care doctor and a psychologist and a nurse and a social worker. So really there is no access to this care there. So this is the only one. So it's an emergency project. For 3.5 years, it's been continuing, and we thought about closing it down. But we talked to the local people, and really, they don't have access to anything else. They don't have where to get medicines from or any kind of medical care. So this is but I agree with you. I'm against mobile groups. I'm for sustainability because mobile groups are about emergency and our project is about sustainability. So your question is very good. When we designed this project, there were some questions from the donors and I also asked, then what? What? So there is a elderly person, they have this code, a piece of paper, yes, we provided for that. First of all, this information is shared with family doctors, but this is a new project from the 1st of August. And what I can see as part of this project, there are tele consultations, remote consultations. After a person received the results of the test, the private doctors look at the results and they do make the conclusions and they give them to the family doctors and the family doctors give a referral or telemedical consultations. Also AI is involved in this project. Of course we don't really rely on it in diagnostics, but still it kind of analyzes and it puts red flags where the family doctor should pay special attention. So this project is not about delivering meds. They don't write prescriptions. They just detect, they tell a person this is what you need to do. If they see a person that this person is not mobile and it's not going to go anywhere for further help, then they themselves contact the family doctor and the family doctor either provides a teleconsultation or gives a referral. So if it's a nursery home, there are like 90 people, for example, you can't really do the checkup in one day. So we come there, we do the checkup, and then next time that we come, this telemedical complex, you can do the photo and video consultations remotely. There is special dermatology equipment that can be hooked up, and this consultation could be done remotely with this equipment. So I totally agree with you about sustainability. It has to be in place, and certain benefits should be for these people who are beneficiaries of this project. Thank you. Let's move on further. Mayor Fastiv, Mikhailo Netezhuk in Kiev region. Glory to Ukraine. So this is a discussion panel. And today, for a few times, I heard some appeals to the self-government bodies that they should take care of the health care, especially the primary health care in Ukraine. So please allow me to tell you something which is not part of my presentation. I just want to talk to you the way I feel in this context that we are talking about now. So the discussion panel is called Family Doctor at the Front Line of the Healthcare. And uh, in front of me, there is March 2022. And Fortunately, our community wasn't under occupation, but the neighboring district, it was under occupation. And our family doctors, they were included into the mobile teams we formed. When one ambulance, we would put a surgeon, a family doctor, and we would give certain medications to them, and they would go to the deoccupied territories where on the sidewalks there was dirt, metal, and human meat. And they were doing the checkups for people who spent certain time under occupation and they had no money, they had no medicines, but they categorically refused to leave their homes. And they said, there is nowhere we're gonna go from here. So they were, they tried to give them checkups and medical help there. So in my memory also what arises now is a second case. My colleague from Zhytomyr region told me 1 month ago a family doctor, a man about 58 years of age, he went to the recruitment office to get some information, and now they sent him to the front lines. They drafted him, and now this community lost the family doctor. So in this moment, I'm thinking, really, what we have to do is we have to thank all the medical workers who are now on the battlefield, on the front line, and everybody is in their own place, because now the entire country of Ukraine is at war for our own future and our Ukrainian victory. Thank you very much. If without the remote, but I just want to ask the audience, please raise your hand. Who believes that the war will end this year? And those who believe that next year? Okay. Without the remote, I can see most of you isn't really sure that the next year the war will be over. So we will need we need to be ready for this if this war continues in this or that form. So when we're talking about things like primary medical care, so certainly we have to first talk about the state security, then about the components, the medical security of the country, and then the primary care place inside the system, because the primary medical care cannot function separately from the secondary and tertiary care, especially in wartime. So all of us, we are obliged to coordinate our work in order to make sure that we survive and in order for us to win. We can't split these responsibilities between the local self-governance bodies, the ministry, the NHS. Quite the contrary, we have to join our efforts together and coordinate our efforts. Unfortunately, me, as the head of the community now, I can't tell you that I can see this coordination. I'm being very honest with you. In our community, you can see in the presentation, we are working, we are trying to develop the primary care, we are trying to realize various projects.
However, when we had USAID, when we have resource, we had possibilities over 7 various projects. We developed this area. Now USAID is gone. And there is no other real alternative. So we see the statistics, we feel the risks, we see the challenges which exist now and which will probably happen in the future. Our community is a small model of a large country of Ukraine, because when in Ukraine we had 52 million, we had 52,000. So many things. Well, I have figures from my community. I just multiply them by 1,000 and I approximately understand what's going on in Ukraine. For example, on our wall of memory we have almost 300 pictures. The birth rate in our community in 2024 reduced twice as compared to 2021. While the number of children with disability at the same time doubled. We see that the average age of stroke reduced. We see that the morbidity of that the incidence of cardiovascular disease is growing. We know the global experience. The war always results in increase of cancer mortality. And of course, it's a big challenge for family doctors. And first of all, we have to work with it. We understand that combat veterans with disability are coming home. I understand that in this hall we have representatives of primary healthcare system. So, tell me please, do you have a package of rehabilitation care in outpatient setting? Yeah. And if we talk about capital city, it's not. But if it's a small country, rural community, in my community I have villages, I have really small settlements. So my question is, what to do with veterans who live in tiny villages? The question is, we don't have professionals with no requirements of the National Health Service, and my impression is that these requirements are imposed without careful analysis of human resources available in Ukraine. Once again, I have a feeling that now we truly need coordination and we need realization. We have to realize that our key goal is to prevail and win, so we must stay together. We are a pilot community. We were about to, with the support with USAID, we were about to engage Deloitte and do realistic estimation of service provision costs for primary and secondary healthcare at the community level. What is the realistic cost of medical care in line with the National Health Service requirements? We have requirements, so what is the estimated cost? Once again, unfortunately, USAID wrapped up, and now we're looking for other partners willing to help us in this initiative. Nevertheless, without coordinated action, we definitely won't be able to ensure medical security of Ukraine. I've once heard an opinion that communities are supposed to take care about human resources themselves. I 200% agree, but I have a question. I know several community leaders. Zhytomyr region, Sumy region, Chernigiv region. They offer vehicles, they offer housing. And I have a question. Are there many people, are there many university graduates who wish to travel 30 kilometers to Belarusian border or Russian border for their workplace? They are looking for such people, but there are no such people. However, people still live in that communities. And in order to protect our Ukrainian land, we need to provide educational services, we need to provide health services in that region. Medical care is truly essential, and we want Ukrainian people to live in that soil. Once again, behind the curtains, I once asked for opinion of the medical community. Maybe it makes sense to consider dual education in healthcare. We are on the way towards human resource abyss, and soon we will face a very acute challenge with staffing capacity, especially given the fact that in the primary health care, in our community in particular, we have 25% of employees who are aged over 75. How are we going to replace them? Young people leave country and seek refuge abroad. Before my election, I worked in industry, and I know that the best thing the enterprise leader can do is to train new workers. You invest in new people, but this person is already at the workplace. They're getting married. Their children are born. You offer them housing. I understand it's unconventional, but maybe it's a potential pathway. Because there is a risk that at some point we will find ourselves at the bottom of the abyss and we will never be able to get out of it. Here we need cohesion. We all need to bring our efforts together. Once again, our community is open for innovation, so I'm willing to collaborate, I'm willing to interact, and I'm willing to answer your questions. Glory to Ukraine! Dear friends, questions to Mr. Mikhailo. Thank you so much for your presentation. Hello. First of all, thank you so much, Mr. Mikhailo. You have been truly proactive in your grant efforts. We made visit to Fastiv Center and we were really pleased. So, we're really pleased that you represent the local self-government, but the officials, and you deeply immersed into challenges faced by medical community. I think our discussion has gone in the wrong direction because we have many leaders of primary health care institutions and we wanted to ask questions to Ms. Natalia, to Mr. Victor, but unfortunately we have no one to ask these questions. So I just want to ask for some explanations. Maybe representatives of National Health Service can provide it. How the primary health care is going to survive in 2026, given the fact that they've just announced increase of wages to around 35,000. It's really important for me. I need to understand how are we going to provide services. Then it's about competition. We all know that now, in the second half of 2025, the primary health care system has the only primary medical care package. We also have package 72, primary care plus veterans. We are using it, but What about funding? The funding is very set. So basically now we have only package left and we have a great deal of uncertainty. How to proceed with verification? E-health system announced introduction of patient dashboard where patients will verify their data themselves and they're supposed to be reliable for it. So now, every institution may claim we have a certain number of unverified patients, and we have no idea who these people are because the National Health Service of Ukraine does not provide us with transcripts and we cannot match them. Are those unverified patients from our communities or some other patients? And why haven't they completed verification? I'm a manager, so I don't understand why verification against the state register of civil status. We have vital records. We have different data for children. For some reason, in July, I have more unverified children. So why they were within the field of systems vision in June, but suddenly disappeared in July. So I want to learn more about your expectations for 2026 and how it can be revisited because the primary health care operated really good. We provided, for example, mobile outreach palliative care. And now these patients are left behind the board of medical guarantee program because no surgeon and no anesthetist will pay home visits to patients. Thank you. Thank you so much for your question. Let me respond to it. Actually, you addressed me personally, so probably I'm the one to speak. We planned this panel discussion in a slightly different format, but we understand that these important venues must produce some really tangible outcomes through amendments to legislation or other solution. The topic of our today's meeting was supposed to be a bit different. We wanted to bring together medical associations under the leadership of Ukrainian Federation of Professional Medical Associations. We wanted to discuss its integration into European professional structures. It's a very important step taken today. We took today, and please accept my sincere congratulations. But as for our today panel discussion, in order to make it truly effective, we need to bring together more stakeholders. So today we have a kind of pilot project. We've heard your concerns and opinions. So I suggest that the leadership of Ukrainian Federation of Professional Medical Associations prepares a venue for meeting between primary health care professional associations, the Ministry of Health, and the National Health Service of Ukraine. It's really important to have owners, community representatives, because they also have a lot of questions, and often they don't understand the direction for development, strategies, roles, and priorities, and what to do in different scenarios. Moreover, we all understand that the country is surviving amidst a full-scale invasion, and financial resources are very scarce and limited, so we need to prioritize. And when we prioritize, it means that someone receives funding and someone doesn't. These are very challenging topics, but we still need to discuss them. So we need to organize this discussion in the nearest future, involving the representatives of the ministry, deputy minister, leadership of the National Health Service. Probably we will also invite association of territorial communities, so we can truly develop a solution before we start execution of contracts under Medical Guarantee Program 2026. Now we still have some time we can use in order to optimize Medical Guarantee Program within the budget allocated by the government for healthcare sector. Listen to voices of primary healthcare providers. Why? Because this is the very foundation. We all perfectly understand it. and make some steps which will bring our services and your services closer to patients, because our patients are in the heart of all activities carried out by stakeholders united around healthcare. So, dear Vice President, I invite you to organize this forum in the nearest future. And Mr. Mikhail, representatives of Community Association, we really want your association to be properly represented. We want government public authorities to develop potential solutions. We want this dialogue to be really fruitful. If you agree with me, let's work on it. Another question, and we need to move on, because we have our timing, dear colleagues. No questions. Fine. Then I give floor to Mr. Alexander Vlasenko, Director General of Kramatorsk City Council's Primary Healthcare Center number 1. I'm sorry. Hello, ladies and gentlemen. I just want to briefly tell you about our center, to give you some context. Kramatorsk, Donetsk region. Before the war, we were the only center in the town, and we provided services to a significant number of declarants. And I had around 700 employees at my center. When the full-scale invasion started, I had around 120 doctors. We had 12 outpatient clinics throughout the city. But we were a unique center of sorts, because back since pilot project in 2012, well, it happened, and I'm really happy that in addition to primary healthcare, we also have a small secondary healthcare component. Therefore, we are more or less autonomous service provider, and we're less dependent on other institutions. We have powerful lab capacities, we have powerful diagnostic capacities, and we have all possible primary healthcare packages, mobile palliative care. We have captured service for HIV-positive patients, services for patients with substance use disorder, TB patients. So everything we could have accepted, everything we could have accepted within the so-called single medical window, and it clearly demonstrated. Well, just for you to understand, I'm a family doctor myself by background, and before I was appointed as a manager, I spent 10 years working as a family doctor. I managed outpatient clinics, so I perfectly understand the philosophy of family medicine. So everything that can be done by primary doctors is can be done, provided proper resource and proper training. So this is just a little bit of philosophy before my presentation. So what is the significance of primary health care before the war? Primary health care level basically bridges public authorities, especially during the war, bridges public authorities, volunteers, various international humanitarian organizations, and the community, helping to coordinate provision of basic medical services. So what are some of our problems and challenges? So we have separate issues. The top one problem is the staff. Security of our personnel. We do have this challenge, because now we are located 12 to 14 kilometers away from active combat zone. And everything happening around every day is when our staff is exposed to it. Constant shell fire, especially now constant, frequent drone strikes, air raid alarms. Air raid alarms triggered after a shell already explodes. So when people come to us and ask, do you go to shelter during air raid alarm? I always answer that it doesn't make sense. Either you spend the whole day in a shelter or you simply close your medical institution. Lack of qualified staff, another big challenge because I used to have 120 doctors, and 2 months after the start of the full-scale invasion, I had only 12 people left. 12 out of 120. Now I have 56. So we have brought people from other regions, but not that much. And during this entire period, 3 years, we hired only 2 medical school graduates. I understand that Kramatorsk is not really a popular destination now, but unfortunately we have what we have. And the main problem is adaptation to a new environment. New clinical guidelines, everything requires prompt response and new training of our workers. So workplace conditions. During the first year of war, we had limited access to resources, very austere conditions, problems with medication supplied, medical equipment, medical devices. Everything was limited, and we had to work amidst constant blackouts, interruptions with water supply and heat supply. Now, because every strike against critical infrastructure may easily result in a city-wide blackout. And it's especially important for us. What do you think is the most important for successful function of our clinic? Internet. It may sound funny. Just so think healthcare and internet, but electronic health problem doesn't work without network access. We cannot register a person, we cannot design a patient journey. If there is no internet access, the system is literally useless. Patient has no idea where to go. We have no idea how to properly collect their data, so it's a very urgent problem for us. We need to ensure uninterrupted power supply and uninterrupted internet access. Infrastructural destruction. Unfortunately, during this entire period, we had 3 outpatient clinics destroyed. But even despite these damages, our institution continues to function. Patients. Our patients have also changed, unfortunately. It's sad, but now we have so many patients of elderly age, so agents 60 or even 70 plus, who need the most attention, most medical attention. And the key challenges include limited access to healthcare and specific types of healthcare. We don't have these diagnostic capacities and wide variety of tertiary professionals as we used before. We have family doctors, but we don't have strong medical infrastructure. Limited access to medications and consumables, a lack of caregivers or family members, because previously patients aged 75 plus were cared by their children. Children were displaced, parents stayed at home, and now doctors receive phone call, "Oh, my mom is unwell. Could you please come to our home and visit her?" Then lack of financial capacity, logistical problems with transportation, and change in priorities. So now during the war, you know, I do support checkups, but unfortunately prevention is not a priority for population now. And medical conditions. The structure, the profile of medical conditions have also changed. Now we have more patients with injuries due to strikes. Patients with chronic condition often present at a later stage, at more advanced stage, and there are growing mental health challenges, and I expect even more of these conditions. Then administrative and organizational challenges. First of all, we struggle to organize provision of medical care on demand. Even at the national level, we don't have strategic vision. We don't have action plans for various scenarios. Uncertainty with funding. I am manager of the institution, and I have no idea how much money I am going to receive next year. Rules of the game are constantly changing. The funding is always changing. Today you receive more, tomorrow you receive less. And for us it's critical. It's critical to know number of declarations because declarations account for 80% of our revenues. I mean funding we received from National Health Service. Then problems with information coordination between various structural units, logistic supply chain challenges. It's a big challenge indeed, because unfortunately we have only two logistical routes which are more or less protected against FPV drones, and they're on the borderline, and ensuring ability to provide medical services and maintaining function of the institution. It's also a challenge. But once again, every crisis means new opportunities. We understand that improvement of primary medical care in Ukraine during the war is a critical and essential task because it's about basic medical services. I have always been a supporter of this model. The reforms were introduced in haste, and the most important component was the training of personnel. So basically, we need multi-purpose people, doctors. We need doctors who can treat both children and adults, but there are many family doctors. Well, they are designated as family doctors, but they are either pediatricians or internalists. So the war has exposed this problem. I had only 12 doctors 12 months after invasion. Great that these doctors were family doctors. Just imagine, 12 doctors, one doctor per outpatient clinic, and this doctor could receive any kind of patient. Just imagine, I have only a pediatrician left, so what am I supposed to do? And it means that even the most basic services could not be provided at the outpatient clinics. These are challenges we have to take into account. Moreover, I deeply respect private family doctors, private providers, individual entrepreneurs, but we need to understand that no individual practitioner would deals with patients who have socially dangerous conditions. I'm an entrepreneur, I'm a private practitioner, I want to deal with patients I'm comfortable with, but who's going to work with STDs, with HIV? When the war started, our substance disorder clinic was the only institution who provided substitution therapy to patients as it was discussed. It's not like I'm proud about it, but we literally helped people until their infrastructure was more or less restored 5 to 6 months after the crisis. So, currently the top priority for us is security. Why? We need secure workplace condition. Secure workplace condition means that our staff will stay in a town, in a city. Kramatorsk, unfortunately, isn't the only city located in the immediate vicinity to the active combat zone. 188,000 before the war. Now our population is around 80,000 civilians, plus around 20 to 30,000 military. And military also need medical care. All general medical conditions. I'm not even talking about combat injuries. So, they also need healthcare, they need vaccinations, immunizations, very basic things we provide. so improving accessibility. Even despite the war, we still have our call center. We had built it back before the war. Moreover, now each outpatient clinic has vehicles. We deliver medicines. We do home visits. We provide services at home simply because there are no other ways to bring healthcare closer to community residents. Until recently, we had have a memorandum with two other communities, and so our doctors traveled to provide services in the area where there was no medical staff at all. I mean, deoccupied villages. But now they don't do it any longer due to extremely poor security situations. I mean, unfortunately, medical vehicles have become target for FPV drones, and the medical vehicles are often exposed to strikes. Once again, lack of staff, destruction of outpatient infrastructure. We collaborated with international organizations to install modular outpatient clinics. Potentially, it's an amazing solution. I personally don't think we need to build outpatient clinics in small villages because you need to hire security guards, you need to build infrastructure. It's much easier for a mobile outreach team to visit the community, do diagnostic tests, provide treatment and go away. So mobile outpatient clinics are an amazing solution. Then supply of medicines. Back in 2022, we opened a medical hub at our institution because many medical organizations started to do what? Distribute medicines to patients. How did they do it? Just a bag of medicines for everyone. Our patients quickly got used to it, so they now come and ask, give me medicines. What kind of medicines? Just give me medicines, free medicines. I will bring them home. We once did paid home visit to an old lady. Her house was literally full of medicines. She collected medicines from international humanitarian organizations because their objective was to distribute. Her goal was to take it and accumulate it. But people who really needed specific medicines were left behind aboard. Therefore, we decided to distribute medicines in a centralized manner. We accept them at our center, we register them, and then, based on prescription of family doctor, we distribute them to patients. Yes, it was extra headache for family doctors, but patients knew that if they truly needed these medicines, they could have access to them at least for some period. Because unfortunately, during the very 6 months after the war, there were only 2 pharmacies opened in the town. Now it's more or less okay, but back then it was a true disaster. Now, mental health support. Mental health support was implemented as part of a number of projects, and we also hired 2 psychologists during the war. Staff training, it's priority for me personally because we found out that now, well, I'm a manager. During the first year, I didn't want to do anything because everyone was overwhelmed, kind of frozen. But you know, any institution that does not develop eventually starts to degrade. So, so I've decided that our future activity would be focused on capacity building and staff development. And we took part in many projects, and now we work in the areas we couldn't even dream about back before the war. So we convinced our city council to install mammography machine. So we installed a digital mammography machine. And now we can offer diagnostic checkups for women without need for referral, because referrals has been always a problem. You refer a patient to different hospitals, the machine is not working, you ask why, they say why do we need it, it's broken, we need to repair it, repair costs money, we don't need it. Now I have this machine at my facility, I can provide the service. Then palliative care. Here we collaborate with two organizations to develop mobile palliative care system. Mobile palliative care must be implemented within primary health care service, palliative care and rehabilitation care, because specialized rehabilitation with a full list of doctors and equipment at the secondary level is one thing, but primary care is a different thing. It's about accessibility, especially for small communities with a limited number of patients. We need to remember that in addition to patients who need specialized rehabilitation with occupational therapists, etc., we also have children. We have elderly patients, and they also need professional rehabilitation care. And it works really well in other countries globally. Moreover, we are the first institution in Ukraine since 2022 who introduced a home visit program for children below age of 3. And our trainers, UNICEF trainers, still work throughout across Ukraine to advance the training and improve the competence. This is a very promising area, I believe. Is patronage services for children, I mean. It's a very promising area of patronage services for children and for elderly people. Mobile outreach teams. I don't really like this wording, mobile outreach teams, but I just want to explain what do I mean by it. So mobile outreach teams, we collaborated with a German project, and what did we do? As I said, we have many patients who cannot reach outpatient clinic. These are mostly elderly patients plus patients with certain health conditions. For example, if a person lives at 9th story and elevator doesn't work, this person will physically won't be able to reach the outpatient clinic. And if this person actually goes down 9 stories by a stair, it will be over. So we shared this function, they distributed this function among our outpatient clinics, and now doctors pay visits to their patients to do preventive checkups, to have appointments, because we understand that otherwise these patients would never reach us. Collaboration with international organizations, yes. So this is just an example for you. Here you see in the top corner, this is our outpatient clinic way back before the war. It was a kind of barn. We just constructed the building. It wasn't yet functional. When the war started, it was hit by a shell. So you see, this is how it looked like after strike, but thanks to support at regional level and municipal level, despite many people saying, oh, it's not feasible, you're exposed to so many strikes, it will be destroyed again. But I believe that back then it was truly essential to motivate the staff and to raise morale among population. We showed that the city was alive, no one was going to give it up. It was beyond our control, but we still did an amazing modern state-of-art outpatient clinic with 2 doctors, even better than it used to be. And finally, all these checkups. It's just a small feedback to previous discussion about checkups. I think checkups need to be implemented at the primary level. So when a project enters my area, I always ask the project team, how are you going to ensure sustainability? Because it's great to have a project. Project implements some activities and then project simply leaves. and everyone is used to new services. Just imagine you receive a benefit and then it's taken away from you. It's not like I'm screening project or filtering. I just discuss with all organizations the sustainability matter. Do you do this project? Do you calculate the cost of intervention? Can we afford it? Because we did have this experience. Or is it something truly sustainable? For example, like a purchase of equipment or training of staff, something to boost our capacity so we can further develop through our own efforts unassisted by projects. So this is example of a project like this. We did checkups, we we did checkups for arterial hypertension and diabetes mellitus. It was a program. It's amazing when the project was functional. It's amazing when every family doctor had access to it because someone gives something to someone and family doctor has no idea about it. And finally and eventually we deal with consequences. So I'm a family doctor myself. When I just started to work as a family doctor and when patients came to me asking for referrals, etc., I told them, you have two options. After I treat you and I work with you, or if you don't want it, then you don't want it. So I always started to work in reverse. First I treat you and then you receive your referral. Yes, I cannot do gastroscopy, but for example, I can prescribe you treatment similar to gastroenterologist. So once again, the status of family doctor depends on family doctor. It really depends on doctors themselves. But of course, there are some systematic issues as well. And another thing, just to wrap up. Probably there are only few institutions who operate in frontline areas and still have relocated units. Since 2022, we have had an outpatient clinic in Kiev. I appreciate the city of Kiev for giving this our opportunity, for accommodating our relocated staff, for offering a place for us. And we also have an outpatient clinic in Dnipro. Now we're looking for more locations for potential relocation because unfortunately the war is developments are beyond our control, and as an institution leader my first priority is ensure that it's functioning as long as it's within my capacity. Thank you so much. Any questions? Thank you, Mr. Alexander, for sharing your brave experience. Any questions to Mr. Alexander? Thank you so much. So, dear friends, we have exhausted our agenda for now. On behalf of the hosts of this event, I appreciate this very fruitful and proactive discussion, and we have agreed that we will continue this discussion and we will engage public authorities, the Ministry of Health, the National Health Service to make sure we are well prepared for Medical Guarantee Problem 2026, and we take into account the opinions of all stakeholders within the framework of our limited national budget. Thank you so much. Thank you. And please and take care and enjoy a nice and calm evening.